Hello, in this lecture we're going to examine the impacts of COVID-19 on those who are undertaking aesthetic procedures. Let's begin by looking at the way that demand from clients might have been affected by the pandemic. There is no specific literature at the moment for aesthetic procedures, but there is some literature around cosmetic dermatology. It's clear from that literature that people are now, in the later stages of the COVID pandemic, much more interested in having cosmetic procedures than they were at the start of the pandemic. And this might be because they better understand the way that such procedures can be provided safely. Analyses of United States data show clearly that the way that people rank the factors that influence their choice about having cosmetic skin procedures done are affected by a range of parameters. And right up front in those are issues around the safety of the facility and, of course, the number of cases in that particular location, and whether the staff who are providing the care in those particular clinics are wearing masks and undertaking other standard infection control measures. Let's now spend most of our time focusing on challenges for clients and challenges for staff as a result of the pandemic, taking into account where we are now. So for clients, it's fairly obvious that because of lockdowns and restrictions, that during the pandemic, that a whole range of elective procedures have been postponed, and therefore there is a build-up or a backlog of such work that needs to be done. It's also fair to say that there has been some psychological stress for clients who would have otherwise regularly have had such cosmetic work undertaken. Flipping the coin and looking at impacts on staff working in the aesthetic area, we can identify three fairly obvious issues. The first group would be related to the wearing of masks or N95 respirators, which can cause reactions on the facial skin. It can also aggravate underlying conditions of acne, and hence the name maxne has been given to this. As well, if there is more frequent hand hygiene being undertaken, either by hand washing or using alcohol-based hand gel preparations, this could lead to a greater incidence of reactions. And this has certainly been documented in the dermatology and nursing literature. Let's look at what happens with continuous mask wearing. We know that when someone wears a mask non-stop for 6 hours, that there are some quite dramatic changes that occur in a number of parameters related to the skin. The net result is that we create quite a different environment underneath the mask versus the areas of the facial skin that are not covered by the mask. The skin temperature of the areas covered by the mask, so this is the cheeks, the areas around the mouth, which are the perioral areas, and the chin, show an elevated temperature. This temperature stabilizes after about 1 hour, and it remains at an elevated point for the entire duration of mask wearing. This is relevant because when you change the temperature, you change the growth dynamics for bacteria and fungi that live on the surface of the skin. There's also elevated secretion of sebum on these three areas that are so-called running hot. And not surprisingly, the redness of these areas also increase. The hydration of the areas around the mouth reduces during prolonged mask wearing. If you measure transepidermal water loss as a measure of skin permeability, this is actually not affected by wearing a mask at all. In this study done from Korea, the upper three images taken using a thermal camera show you the skin temperature before, after 1 hour, and after 6 hours of wearing a mask. And the actual numerical data is shown on the graph immediately below. And you can see that there is no change in this elevated temperature from 1 hour across to 6 hours. We know from other studies that there are some alterations in the pH of the skin, and the pH will fall slightly if you're wearing a medical mask, and it will also fall if you're wearing a cotton mask. This study also showed some changes in transepidermal water loss, but the variations were quite large. In this study, there was only 3 hours of continuous mask wearing. When you look at the literature around members of the general public who have had to wear a mask for a long period of time, you see a similar pattern of things, with a prevalence of just under 55% of individuals reporting one or more adverse reactions for the skin that's underneath their face mask when they've had to wear it for a long period of time. The 3 most commonly reported complaints were a worsening of pre-existing acne, rashes, and itchiness developing on the skin. The risk factors which make these things much more likely to occur are, not surprisingly, the longer you wear the mask and not changing the mask after using it, so coming back and wearing exactly the same mask the following day. This is an issue because the polypropylene fibers inside the mask have reduced charge as you wear them, and as they're exposed to moisture, the performance of the mask declines, and it's therefore more likely that the mask is going to trap moisture against the surface of your skin. When you look at the distribution of skin reactions to mask wearing in people who do this for long periods of time, you can see, as shown in this study from Korea, that these reactions tend to be most prominent in the pre-zygomatic areas over the side of the cheek, around the point of the chin, and immediately around the mouth in the perioral area. We know from many studies that wearing a mask will increase the likelihood of some dermatological reactions around the face. This is modulated or changed by a whole range of things, including the frequency of changing masks, the way the masks are applied, the education of the individuals, and so on. The routine wearing of masks in healthcare settings has been common for many decades. In my own professional practice, I've been wearing a mask to see practically every patient since 1985. So why don't people, for example, who work in dentistry, who wear masks all day, every day, not develop these sorts of problems? Well, the answers are actually quite straightforward. We wear new masks for each new patient, and we don't have this problem of the mask effectively being clogged up with moisture. And between patients, we are giving our skin a chance to rest. This means there are some significant issues for people who wear the same mask day after day. This is a very nice recent systematic review of the adverse effects during the COVID pandemic of wearing a face mask, according to the medical background of the individual. So not surprisingly, those with so-called sensitive skin have a greatly increased risk, over 3 times. The data here are shown as the odds ratio. So an odds ratio of 3.40 means you're 3.4 times more likely to show an adverse reaction if you have sensitive skin. If you have atopic dermatitis, the risk is elevated by almost 2-fold. If you have an atopic predisposition because you suffer from hay fever or asthma, then you're also more likely to show an adverse reaction to wearing a mask. If you already have acne or have had acne in the past, then you're 30% more likely to see an aggravation of that acne when you wear a mask for a long period of time, and likewise for seborrheic dermatitis. The top 5 complaints that you see in the literature for prolonged mask wearing are itchiness, an indentation of the facial skin, pain around the ear caused by the elastic strap of the mask leading to discomfort, redness of the facial skin which reflects this underlying inflammatory process, and also dryness. These problems are worse with N95 respirators than they are with surgical masks, also called medical masks. And this is to do with the seal. An N95 is designed to seal around your face, so it's going to trap moisture more so than a surgical or medical mask, which doesn't form an airtight seal around its boundaries. And not surprisingly, regardless of what you're wearing on your face, the longer you wear it, the greater the likelihood of having an adverse reaction to it. Let's now spend a bit of time looking at masne, which is effectively an amplification of a true underlying acne vulgaris issue. Acne is an inflammatory disease of the skin that is focused on the pilosebaceous unit. We know that masne occurs as a direct result of personal protective equipment, such as a mask or respirator, being worn in a person who previously has had acne or currently has acne. The reasons are this humid microclimate that's created between the mask or respirator and the surface of the skin. And this leads to greater bacterial growth on the surface of the skin. It's also been argued that if there is a very close-fitting mask, then this might be causing some possible occlusion or irritation. It could partially block the openings of the follicle and therefore amplify the effects of the heat and the humidity. This very nice paper summarizes some of the interactions that are going on here and how factors such as the breathability of the mask, how close it is to your skin surface, the relative humidity, the extent of moisture in the environment, how much you sweat, all these factors can influence the likelihood of developing inflammation underneath the mask and exaggerating a pre-existing acne problem. The topic of aggravated acne from wearing a mask has certainly featured on social media, and indicated here with the arrow are the contributions by people who work in aesthetics and people who are beauticians. And you can see that there is a range of different topics which they have tweeted about in relation to mask-related acne. So when we're thinking about how to manage this problem, what are some of the key questions to ask? Well, the story begins by thinking through what could be causing inflammation on the skin, because not all problems on the skin related to wearing a mask are in fact acne vulgaris. They're mostly irritant dermatitis. Second in prevalence after irritant dermatitis are allergies, particularly to what are known as cross-linking agents. The most common of these is a molecule known as thiuram, which is a cross-linking agent used with natural rubber latex and synthetic rubber materials, which are used in the elastic straps or ear loops that you find on masks. These give them the ability to withstand being stretched many times the length without snapping. These can be found in masks of all different types. Acne is actually not the most common reason to get a reaction to wearing a mask. So if you're going to manage mask-related issues, the following questions apply. How long is the person wearing a mask for at one stint? How often are they changing the mask? Are they wearing the same mask day after day? When are they taking a break so that their skin can return to a normal temperature and humidity? What happens over the weekends and non-working periods when the person is not wearing a mask? If the problem is driven by irritancy or by allergic reactions, then both of those should improve when the causal factor is not present. However, if it's an exacerbation of underlying acne vulgaris, once that's been established, it takes much longer to resolve, and it's certainly not going to quieten down over a couple of days. Another key question is the skin barrier intact? If the surface of the skin is not intact, then any allergens in the environment are going to penetrate much better. This is why people who've got quite dry skin should be using moisturizers or barrier creams in order to maintain the barrier function of their skin and reduce their exposure to allergens in their working environment. Let's now look at conditions that would be present before the pandemic in clients that will be worsened when the patient gets a COVID-19 infection. This would be true whether it's a symptomatic infection or whether it's an asymptomatic infection. So the classic conditions here are alopecia areata, which is a form of hair loss. We'll talk more about that in a moment. Psoriasis, lupus erythematosus in its various forms, and pemphigus, which is a vesicular bullous disorder. Why COVID-19 infections makes these get worse is because COVID infection is a hyperinflammatory disorder where people produce excessive amounts of inflammatory cytokines. And this exaggerated immune response basically derails the underlying host immune response. And these four conditions all have an autoimmune basis. The person's immune system is reacting against themselves. So when you turn up the volume with a cytokine storm, it's not surprising that those conditions all get worse. You could also argue that the fact that the person has been isolated and in lockdown, unable to access timely medical care because of limited medical services or not being able to get medicines or adhere to a treatment protocol, could also make their disease worse. Let's now look at the skin conditions which can occur in people who get COVID-19 infection. These could be clients or they could be members of the staff. The piece of glue that joins all these together is it relates to dysfunction of the endothelial cells that line blood vessels in the dermis, which is the layer underneath the epidermis of the skin. The epithelial lining of the respiratory tract, for example, the surface of the tongue or the lining of the bronchioles or parts of the breathing system, carry the receptor known as ACE2, which allows the COVID-19 virus, SARS-CoV-2, to bind and then infect cells. Fortunately, this ACE2 receptor is not expressed on epidermal cells, but it certainly is found in the endothelial cells. There are large numbers of these endothelial cells where we have capillary beds, for example, around the fingertips. So not surprisingly, some of the distribution of skin conditions in COVID is going to vary according to the vascularity of the area. Something that makes skin disease caused by COVID a bit tricky is that when people have very dark skin due to their ethnic background or because they've been through, for example, a tanning process, or they spend a lot of time outside and their phototype has given them a very darkly tanned skin, it's actually quite hard to see redness in the skin when the skin is quite tanned and pigmented. So the diseases that I'm going to mention to you, some of those might actually be missed because of this masking effect of pigment in the skin. Now, there is a vast literature on skin conditions caused by COVID with well over 1,500 publications on this topic. So I'm just going to synopsis what some of the key take-home messages are from this very large literature. The first point is the likelihood of showing a skin lesion when someone gets a COVID infection can vary from as low as 0.2% to as much as 45%. Many of the systematic reviews that combine data from a large number of studies report a frequency of about 6%. But any individual person, of course, can vary greatly from this average statistic. So let's look at the most common sorts of lesions that might present. The one that's often described are these flat maculopapular eruptions on the skin, which look like a type of rash. These are seen during the acute infection. And the top two photographs on the right-hand side show typical examples of these. There are lesions known as erythema pernio-like lesions or EPL lesions that can follow an infection with COVID. Likewise, there are livedo lesions such as reticularis racemosa that can also follow an infection, as well as blotchy discolorations of the skin that are purple, known as purpura, and unfortunately necrosis of the extremities, such as the example of COVID toes that is shown immediately right of the slide. There are other lesions such as itchiness or urticaria, eruptions of vesicles and so on that can precede the clinical signs of an infection, such as coughing or fever. So it's been quite a complex story to try to unpick what is actually going on. But the things that these all share in common is this story about involvement of these blood vessel lining endothelial cells. As well, when people get COVID, they can also get reactions to drugs that they're taking. For example, when they get fever, they might be taking analgesics, non-steroidal anti-inflammatory drugs, and these can cause a range of skin lesions. As well, when someone gets COVID-19 infection, they can go through what is known as post-viral anergy, where the immune surveillance that they have doesn't contain long-standing sequestered viral infections, which then reactivate. And the classic example of this is herpes zoster, and the reactivated viral infection is known as shingles. So someone can develop shingles simply because of the fact that their immune system has been messed up by getting COVID-19. Here are some not so gory example of the COVID toes, and what you're seeing here is this discoloration, this increased redness, this purple color, which is coming about because of changes due to the blood vessel network in the dermis. This nice summary, which was published in a South American journal, shows how you get different patterns of skin presentations depending on whether the person's COVID symptoms are mild or whether they're asymptomatic. If the person gets severe COVID, for example, and ends up being in hospital for a stint or perhaps even in intensive care unit, they're much more likely to get some of these more extreme complications, such as COVID toes and these quite extensive purpura types of conditions. And the reason for this is that COVID causes problems with coagulation, and many of these problems are going to be expressed in the skin, not only centrally in organs such as the heart and the kidney. We can see here the distribution of lesions of the skin in people who get COVID according to their anatomical location. And not surprisingly, large areas like the trunk account for a reasonable number of these, but there's certainly a propensity for them to occur at the end of the extremities, basically the fingertips. And this is referred to as an acral distribution or the acral area. COVID infection can cause changes in pigmentation, and as shown in this particular study, there can be less pigment, such as example A on the left-hand side, where one child patient is compared to their sibling, and you can see areas where there is greatly reduced pigmentation. Or, on the other hand, as shown on the right-hand side, the pigmentation can be greatly increased and there can be hyperpigmentation. Once again, these can all be due to inflammatory events inside the structure of the skin. There are a range of alterations to the nails that have been described with COVID. The first major alteration is known as the Lindsay nail or the half and half nail, where the most distal part of the nail, that is the part that's nearest your fingertip, has a red, pink or brownish discoloration, and the nail which is further back towards the nail bed, closer to your finger, is more of a whitish appearance. And you can see those shown on the examples on the right-hand side. Now, this is not something which is unique with COVID. It's seen in a range of chronic diseases, and most famously in people who have got chronic renal failure and may be progressing towards end-stage renal disease. Here are some further examples of alterations in the nail during COVID. This is known as the red half moon, where you can see these convex bands that go over the nail like a red half moon. Because of the alterations in nutrition and overall health, you can also see some physical deformities develop in the nails. The left is an example of what's known as Mies lines, and these are lines in the fingernails that blanch when you push on the fingernail. The example on the right is known as a Bose line, and this is an actual groove in the structure of the nail. So if you spend time looking at nails, you might notice some of these types of anomalies in people who've had COVID-19 infections. It's time to move upstairs and look at the hair, because there are a range of different problems with hair loss that are well documented to occur with COVID-19 infection. And indeed, this can be one of the more distressing aspects of the disease when a person has cleared it and they then start to see problems with their hair afterwards. The problem of hair loss during COVID is something that someone's going to notice large amounts of hair being removed on their hairbrush. What's going on here is that the pro-inflammatory cytokines that are overproduced during COVID can cause a kick of the hair cycle, moving it from anagen up into telogen, and this causes the shedding of the hair. As well as this, we can have these thrombotic reactions that are occurring at the level of the individual hair follicles. And there may even be some viral infection in the endothelial cells around the hair follicles, and these endothelial cells can then produce pro-inflammatory mediators or can actually die off. Hair loss during the COVID was popularized when Alyssa Milano, an actress, reported this on Instagram and showed examples of a large amount of hair that were coming off her head when she was just brushing. There are a range of different conditions that can cause hair loss in COVID, and three of these, telogen effluvium, androgenic alopecia, and alopecia areata, all have got some significant connections to a person's state of mind and their emotional stress. But in fact, there are lots of other conditions related to the skin that also show quite strong connections to a person's overall sense of well-being and emotional stress. And this is true for conditions like eczema and psoriasis. So let's just go for a bit of a deep dive into hair loss due to COVID-19 infection. So alopecia areata is a condition which is autoimmune, where there is non-scarring loss of hair driven by inflammation at the bulb region and loss of the so-called immune privilege of the hair follicle, where the stem cells get targeted and they undergo apoptosis and die off. This condition is not common in the community, but it's seen at about a 3% frequency in people who get COVID-19 infection. A very common condition seen in the general community is androgenic alopecia, also known as male pattern baldness. This condition doesn't only affect males, it can also affect females. And androgenic alopecia has a frequency of about 30 to 40% in people who get a severe illness. And as a result of this, their hairline will recede into that characteristic M shape with the hair thinning near towards the top of the head, and they might progress to partial or complete baldness. However, these are not the two most common forms of hair loss. It's the third one, acute telogen effluvium, which is far more common and has been documented to occur in up to 60% of situations, even when people get very mild COVID-19 infections that they may not even be aware of. And it causes diffuse non-scarring shedding of the hair, but often is associated with trichodynia. This is when you have a painful sensation when you touch the hair or when you brush the hair. And that can obviously be quite debilitating. It's bad enough seeing your hair come out, but when it's painful as well, that really increases the aggravation. Telogen effluvium is not something which is unique to COVID. It's well documented to follow all sorts of severe infections with fever, severe traumas, and severe psychological stress. And you can argue that COVID-19 infections bring all three of those things to bear. It has a much higher prevalence in females than in males, and it's particularly common in elderly females as opposed to younger adult females. So here are some examples looking down at the top of the head on the scalp of a couple of individuals who've got telogen effluvium. And here are some further examples with some quite severe manifestations on the left-hand side, where the hair pull test will remove 40% of the hair versus 20%, which is the number for the case on the right-hand side. Here is a recent comprehensive systematic review that came out in December of 2021. It drew on the data from 19 studies, so it's going to give a fairly broad picture of what's happening in this condition. There was a preponderance of cases in females as opposed to males. These women all had a lower density of hair, and many of the hair follicles were empty, having shed the hair. The duration from when they first got their symptoms of COVID to when their acute telogen effluvium developed was on average 74 days. So at this stage, the subjects would likely have felt that they were over the COVID infection and it was really something in the past, and now their hair begins to fall out. Fortunately, most individuals who did develop TE recovered from their hair loss, and all of them found that the late onset of this increased shedding of hair after COVID was emotionally very distressing. We know that the trichodynia pain problem is much more common when someone has a severe COVID infection as opposed to a mild one. And that's shown in this nice study here. The bars in blue are those who have a mild COVID infection. So they're much more likely to have just plain TE by itself than to have TE combined with trichodynia, whereas trichodynia is much more common in people who have had either moderate or severe COVID infections. In fact, the authors of this study made an interesting observation. They suggested that when someone suddenly develops TE, that they might have had a minimally symptomatic or asymptomatic infection and not be even aware of it. Let's now talk about phototherapy during the pandemic. Phototherapy is used for a range of different things, from skin rejuvenation through to hair removal, tattoo removal, and so on. Not surprisingly, the COVID-19 pandemic caused the closure of many clinics that were doing this type of work because of various lockdowns and restrictions that were put in place. And the driving logic behind these was to stop people moving around and to keep them separated from one another in order to maintain social distancing to reduce the spread of the infection. And clearly, this is all driven by public health directives that are issued at the level of the individual state or jurisdiction. So in Australia, as you'd all well know, we have very prominent chief health officers, John Gerard, who took over from Jeanette Young in Queensland, Kerry Chant in New South Wales, and Brett Sutton in Victoria, and their parallels in other states and territories. These are the individuals who are empowered under the state public health legislation in each state or territory to issue such directives. Currently, the risk of spreading COVID-19 in a clinic where patients are undergoing some form of phototherapy isn't actually documented. However, the general principle is that because if you were treating an area of the face, around the nose, around the cheeks, for example, it's going to bring you into the patient's breathing zone, and a close proximity to the mouth and nose will bring you into contact with the aerosols that are generated by the patient when they breathe and when they speak, because breathing is an aerosol generating behavior. And this is why it was originally suggested in some early guidelines that the treatment of facial lesions should be minimized or avoided when there were very high case numbers in the community, since it was highly likely you might be seeing cases that had asymptomatic infection. In the US, a group of dermatologists got together to produce some recommendations for phototherapy during the COVID-19 pandemic, and they were published in July in the Journal of the American Academy of Dermatology. Basically, they recommended that patients be screened for symptoms based on local guidelines, and in Australia, those local guidelines are put together by the individual state and territory health authorities and their public health units, and they describe what is a pattern of symptoms. In Australia, the Communicable Diseases Network of Australia, known as the CDNA, puts together what's known as the Series of National Guidelines, or the SONG document, to reflect what's happening in the pandemic around the country. So that's the place to go to get a list of what the current symptom patterns are. There's advice to limit the number of people who are coming in to accompany the client or patient, the use of hand sanitizer, social distancing, wearing a cotton mask for the individual client or patient, having them use hand sanitizer as they enter and as they leave, making sure that if they're given goggles to wear or other eye protection, that those are thoroughly cleaned over with a disinfecting wipe. If the patient is removing articles of clothing for any reason, to make sure that those can't contaminate a surface or come in contact with other people, and to try to keep people socially distanced, particularly around the reception or waiting area. The American guidelines also gave advice to staff to reduce the flow of patients, and this was designed to reduce the physical number of people at any one time, because this affects the amount of virus that might be present in the air, to try to separate the chairs in the waiting area to achieve social distancing, to have the staff wearing a mask or surgical respirator, to have the staff use hand sanitizer after their individual moments of coming in contact with patients, to avoid touching areas where there may be contamination, and to disinfect all the high-touch areas. And these are in line with a whole series of guidelines used around the world during the pandemic. There has now been some follow-up reports on the implementation of those phototherapy guidelines during the pandemic, which shows that they were highly successful and there weren't documented cases of the acquisition of infection in those workplaces that were included in those particular studies. So that's an excellent result. There's also now some literature emerging that some of the light sources that might be used in some aesthetic procedures might themselves actually have some antiviral actions on human coronaviruses. This has not been tested using the SARS-CoV-2 virus, but using the normal endemic strains of coronavirus, of which there are 4 that circulate around the world all the time. So these are quite good surrogates in order to test things that you might want to try. So what they did in this laboratory study was to have the viruses in a culture plate, as shown here. This one's got 6 wells, and then above that is a platform which holds the individual LEDs that are producing the pulsed blue light. And the lights were then run at different settings, and then the amount of surviving virus was then measured. And what they were able to show was that for 2 of these endemic strains of human coronavirus that circulate around the world, there were actually some quite useful reductions of around about 50% following irradiation with these pulsed blue light sources. This is the first virus strain, and then this is the second virus strain, and you can see how the results are very similar between both of these. Based on this, the authors predicted that there would probably be similar effects on SARS-CoV-2, the virus that causes COVID-19. Finally, I just want to touch on some of the challenges of what's known as long COVID or long haul COVID, because it's highly likely that you will come into contact with people either at your workplace or in your general life outside work who will be suffering from some of the downstream complications of having an infection with COVID-19. So when someone gets a case of COVID, if the case is relatively mild and they get a fever and a cough and they feel a bit tired, they get some muscle ache, they would generally convalesce at home and just stay out of circulation for a week or so. Now, during that time, they've got elevated levels of a number of pro-inflammatory cytokines, particularly interleukin-6, tumor necrosis factor, and so on. If someone gets a severe infection with SARS-CoV-2, and they end up going to hospital, going to ICU, and perhaps even needing a ventilator because they've got acute respiratory distress syndrome, they have many more circulating inflammatory cytokines. And this is why what they have is called a cytokine storm. The implications for them are not just damage to the lungs and the respiratory system, there's actually damage across the entire body. And the pattern of this varies from one person to the next, but as we'll talk through, there are over 100 different symptoms that can be a consequence long-term because of this cytokine storm, that this person may be suffering for months or indeed even years into their life. So first of all, when someone gets COVID and recovers, normally their symptoms are significantly dropping down by 4 weeks. Some people will show some persisting symptoms, often shortness of breath, for example, or tiredness, and this is known as post-acute COVID. This runs from week 4 to week 12 after the start of the infection. Anything which runs from 12 weeks, which is 3 months and longer, is known as long COVID or post-COVID syndrome or long haul COVID. If we just line up the symptoms of acute COVID and long haul COVID, we can see that they are different. If we just pick on one of these and look at the lungs, during COVID, someone's got respiratory failure and they've got acute respiratory distress. They often go on to develop a bacterial pneumonia. Often when they're ventilated, they will inhale their dental plaque. However, during long COVID, someone can have chest pain and develop pulmonary fibrosis in a way that's not entirely different to what happens when people inhale very, very small industrial particles, such as nuisance dusts. The pattern of neurological involvement is also different. When someone has an acute infection, they can have a state of delirium, whereas neurologically, when someone's got long COVID, they're more likely to go on and develop conditions such as depression, anxiety, and disturbed sleep, as opposed to the delirium, which often causes an acute psychosis that you might see during an acute infection. Very often when people get long COVID, the thing that they notice most is a reduced amount of energy, just a general fatigue and tiredness that just saps their energy. They often have a persisting headache or frequent headaches, shortness of breath, also known as dyspnea, and they'll often show a partial or complete loss of their sense of smell and taste. And the last one greatly reduces their sense of enjoyment for things like cooking and eating. Over the long period of time, they can go on to develop, as we've just seen, hair loss in various ways, as well as depressive illnesses, mood disorders, problems with sleep, and so on. And these can be quite debilitating in terms of their quality of life. Whether the person was hospitalized or not makes a very big difference to the likelihood of them getting symptoms of long COVID. This study compared people who'd been hospitalized during the acute phase of their illness with people who hadn't. And the size of each of these circles represents the frequency or likelihood of these post-COVID symptoms developing. And you can notice how much smaller the corresponding circles are on the right-hand side in the non-hospitalized people who had less severe illness. So the more severe someone has an infection of COVID, the more likely they are to develop symptoms of long COVID. But even people who are not hospitalized can develop long COVID. What are some of the other risk factors that we know about? The more initial symptoms of COVID you get, the greater your initial severity, the more likely you are to get long COVID. Female gender, as we've already mentioned, is a risk factor. If a person has a pre-existing comorbid condition, if they've got pre-existing kidney disease or heart disease, if they're elderly, then these things increase the likelihood of them having post-COVID. And there is a suggestion that there are also genetic and epigenetic factors that can also influence the risk. But that is an evolving story at the moment. What is happening in people who get long COVID is basically two things. Summarized nicely in this diagram, on one side we've got long-term tissue damage in the lungs, in the heart, and in the nervous system. And this is why people get problems with their heart, their lungs, and why they get problems such as fatigue and headache and so-called brain fog that makes it difficult to think through things. They also have unresolved inflammation. So this cytokine storm that occurs during the acute illness doesn't disappear altogether. but high levels of cytokines persist locally, and there may even be ongoing low-level persistence of the virus. And this can drive problems including chronic inflammation, leading to, for example, joint and muscle pain, imbalance in the microbial flora of the gut, causing dysbiosis, and a greater likelihood of autoimmune diseases. The long-term effects of COVID have been documented in a very large number of studies, and in this particular review, the size of the circle gives you an indication of the importance of the particular problem. And what I want you to notice, first of all, is just the diversity of different sorts of complaints that people can have. And when people get long COVID, 80% get at least one symptom. It's very unusual people to have only one problem with long COVID. They generally have multiple. And it's likely that they're going to need to seek further medical care, often at not just a GP doctor level, but often at a specialist or hospital level because of some new condition that they didn't have before they had COVID. We can see summarized here on this bar chart, arranged in frequency from highest to lowest, are just some of the more common types of complaints that people who have long COVID will suffer from. With fatigue, muscle weakness, pain, discomfort, anxiety, depression, and brain fog or impaired concentration being very much at the top of the list. If you look widely across the literature, you'll find that across the 250 odd papers, which I've looked at least, that there are now quite a few studies that report more than 50 individual complaints that have been identified by looking at many studies together in what are known as meta-analyses and systematic reviews. In fact, a paper published in November 2021 identified more than 100 persisting symptoms of people who had long COVID. So it's clearly a disorder which can have many different types of manifestations, but all of them are problematic, albeit in slightly different ways. The key take-home message is that once someone's got long COVID, be they a young adult or a child or an older adult or even an elderly person, then they're going to need much more in the way of health interventions in their life. If their long COVID symptoms are mild, they might be able to get by with just some teleconsultations and some light surveillance. Whereas if they're moderate, they're more likely to need intervention, for example, through their local doctor or medical specialist. And if they're severe, they're likely to need to be seen in a hospital and to have many specialist areas involved in their care. And one of the things that we don't know much about with long COVID is what the long-term prognosis is for some of these particular complaints. We know that developing lung fibrosis is not good for someone's longevity. It's simply far too early to actually tell. But it's clear that COVID can have some very significant long-term health issues, and this is one of the reasons why containing the disease with effective public health measures is such an important thing to do. So there we have it, the different ways that COVID can affect you as a person working in the aesthetic area and can affect your clients and members of the community who've sustained an infection of COVID-19.